I got into medicine because I think it's a really nice combination of being very intellectually engaging, but being able to apply that in a way that has a very real, deliverable impact on other people's lives. What really drew me to pulmonary medicine is that there are these chronic diseases, asthma and COPD in particular, that have huge global and national impacts from a morbidity and unfortunately mortality perspective. So the ability to even indent on that just a little bit is just very appealing to me. I specialize in pulmonary and critical care medicine, and I spend really the majority of my time treating patients with asthma, COPD, and alpha-1 antitrypsin deficiency. Most commonly we'll hear shortness of breath, cough, wheezing, and often they don't know that they have these conditions when they present to me, or sometimes they think they've been diagnosed with those conditions but actually have something else. When I meet a patient for the first time, it's actually one of the more enjoyable experiences I have as a physician. So we really try to start from day one. A lot of it is just history taking, understanding an individual, understanding prior exposures, experience, and then also trying to understand their philosophy of care, because everyone's a little bit different in terms of what they're trying to achieve and what they're trying to accomplish. The fundamental mainstay of treatment is really around inhaled or nebulizer therapies, but as patients start to get more severe or don't necessarily respond to those kind of basic treatments, we have other oral pills or injectables like biologics that can really help control symptoms and have really shifted the paradigm for patients with more severe disease. One of the other parts of our care that we're really pleased about is we participate in a lot of research trials. So sometimes we'll be able to offer therapies that are, of course, approved and on the market, but we also, for patients where they might not have available therapies, are participating in studies that we can also get patients enrolled in. And there's a lot from what I do on a day-to-day basis that I find rewarding. I had a very nice woman who couldn't attend church and other services because perfumes would trigger her symptoms. So there's this kind of below the surface quality of life impact that is perhaps not as readily available that I really like to unpack. And then I think once we better understand that, then we try our best to tailor therapies to allow people to do what they want to do. So we really try to meet people where they are. And then medically, we're really understanding a lot about these diseases that patients X and patients Y with the same disease are not necessarily the same, and they should be treated differently as well. They've thought that they've run out of any options, and being able to restore some quality of life, really it just gets me out of bed every morning. The majority of my life outside of pulmonary disease is occupied by our two young boys, which is wonderful. It very quickly resets you when you walk in and a young boy starts yelling out data and running towards you.